communities and life.
Yeah, I couldn't agree with you more. I think one of my big points is that we it's implied in our science, this notion of causality, but we never talk about causality as an example, and we never talk which, if I can back up to that, it's really important to understand what the nature of causal sequences is that results in disease. Right now, we think a single blunt physical beginning, a mutation or an exposure, can account for a disease, but that's just not true, and there are too many exceptions to that to trust it as anything like a scientific explanation. But beyond that, I think I also agree with you. It begs the question, what constitutes a good or better explanation? And that's why I'm such a fan. I know Wayne knows this, but I'm such a fan of David Deutsch and his book, The Beginning of Infinity. And I would recommend to anyone interested in philosophy of science, there's a guy named Brett Hall who has a brilliant podcast. He's an Australian philosopher of science, Brett Hall, that reviews in detail, really illuminate over the writings of David Deutsch. But all these things ignored forever by doctors, especially the doctors who want to wave the banner of science. I think all these things are really important, and you're 100% right. It goes to the epistemology of this science, which no one has dared to talk about, at least not during the time I've been an MD.
Yeah, we're all stuck, bottled up with a bunch of, forgive my French, goddamn logical positivists who don't know that's what they are, and are limited because of that logistical framework. Now, this is, pretty highfalutin stuff, but it may be that part of the challenge that faces this direction is to create a new epistemology of science and medicine that actually focuses on what kinds of proof we need about processes that improve the health of individuals and communities and strengthen democracy instead of deconstruct it. That's a big ask. But on the other hand, the attempt to do the science when the science has been fundamentally neutered seems like it needs to be approached with tremendous caution. One small note: when you're ready to do research, I have a son in Philadelphia who Larry knows, who's doing a post-bac pre-med at Jefferson, has heard about your work and would love to help on the research.
Okay, Larry, can you make a note of that?
Yep, I got it. His name is Gabe.
Gabe? Okay.
Yep.
Yeah, good to know.
Michael, let me just say that I agree with you completely. The framework for determining what is evidence and what is valuable evidence, okay, what's evidence that's useful for making decisions about healthcare is distorted towards a hierarchy in which at the top of the hierarchy, which is what everybody plays to and attends to in guidelines and meta-analyses and all that kind of stuff, is primarily a regulatory framework. Okay.
Right.
It's primarily about, can you prove this is better than a placebo control, which is primarily about, can you get it FDA approved? So there's all kinds of other evidence that decision makers in healthcare need that is different than that in order to make rational decisions about evidence-informed, evidence-based, it should be called evidence-based medicine. And so reorganizing the hierarchy And demonstrating that the hierarchy needs to be changed is a fundamental thing. Otherwise, all we get is what is real, is what the pharmaceutical companies and the FDA want. And the rest, and we as family physicians then have our armamentarium gutted, absolutely gutted. So we have no tools as long as we buy into that. And family docs have to say, stop. This is not sufficient evidence for making our decisions as clinical folks out in the field, and it's not sufficient for patients to do that. You need to shift what is the definition and the criteria for what is good evidence. And I've written about this years ago. I proposed something called the evidence house, in which different decision makers need different types of evidence, and that's what determines what type of evidence you need. And then, of course, you need good quality in each one. You need a good anecdote, right? Not just a story, but documented that this is valid and it actually happened and all that kind of stuff. And you need good observational studies and that type of thing. But those are all useful for different decision makers in medicine. And that's where I think a fundamental focus on research research design, and PCORI should have been doing that, in my opinion. That's what PCORI should have been doing. But they haven't really gotten at that core question of, is the paradigm that we're using, the pyramid that we're using, the hierarchy that we're using for evidence-based medicine valid for people? And they never got that deep in their questioning and exploration. And so we haven't quite got there. They moved, it's important, they're doing good work and they're moving in that direction, but they haven't asked that fundamental question that you just said, you just talked about.
This is the only time, in however many years I've done medicine, the only time that I've been part of a discussion like this. And yet I've been sitting and thinking about it for years and years and years. It is the core issue that I'm not sure I know how to get at, but is so important to all of us, because it's the only way to struggle against the biases. I don't know if you guys have been listening to the Alzheimer's disease stuff that's out there, and what counts as evidence in that world, but it turns my stomach.
Yeah.
Because it's just like outrageous, and yet it's the state of the art in Alzheimer's disease.
That's the way it is in every other condition, I can guarantee you.
Yeah.
Okay? Because we use the definition of what is knowledge and what is real that is completely controlled by a single decision maker group.
Yep.
That is not the people and it's not providers.
Can I give you the perfect example of that, Wayne? Just happened to a friend of mine, a 70-year-old woman, zero history of any kind of adverse cardiac event going back generations in her family, extremely fit, no intercurrent illnesses, just perfectly healthy woman. She goes in a new primary care doctor and calls normal, looks at the labs. Her cholesterol is, we're all sitting down, 206. So the primary care doctor, this happened last week. Primary care doctor plugs that into her algorithm, and you know what the algorithm is based on, and says inaccurately to her, because she doesn't tell her the time frame, which is 10 years, if you guys don't know this algorithm. She says, you have a 7% chance of having an adverse cardiac event. That's one. Then she says, 5% is our cutoff for non-treatment. Therefore, I'm starting you on Lipitor today. It's all there. And this all has the patina of science, because you got computers and algorithms and guidelines and screening tools.
And a drug that's paid for.
Yes, very
And-
importantly.
and $4 trillion of expenditure to back it up. And $4 trillion of expenditure that is there trying to defend that expenditure, because that's where, that's how people make their livings and that's how they're getting rich.
Yeah. Hey, Wayne, can
So-
you send me that article if it's easy? Because I just at the Andrew Weil meetings in Tucson, and they're hot on this topic, and they would love an article like that to incorporate in their folder, I'm sure.
Yeah, it was a very short, simple article. I've published a number of more elaborations on it in chapters and books and other published articles. But the core message was published in 2001 in the Western Journal of Medicine, which basically described this. But there's more details of that, and we have approaches to do that. I'll be happy to send that to everybody in the Western Journal of Medicine. It was written with was it written with Dan Moorman? I don't know. No, Dan Moorman was the one about meaning of medicine. But anyway, it was written about the evidence, changing from an evidence hierarchy to an evidence house, and why we need to do that because of the decision makers in healthcare. So I think, do any of you work with the Academy Health? Are you familiar with that organization, Academy Health?
I did 20 years ago, but kind of gave up.
Yeah, so Academy Health has merged in the last couple of years with another organization, and they've gotten a lot bigger. And they're sponsoring, symposia and conferences, and JAMA has got involved with them and that kind of stuff. Anyway, they're primarily interested. I talked with the director of it recently, and they have a big emphasis on research methods and research design, and they're a pretty mainstream group. I mean, I think they have a pretty good. So that's why I asked you all if they were an influential group or not, if you were familiar with them or not, because they've asked us if we would work with them, and they're very interested in this topic, in sort of discussing this topic. So I'm kind of debating whether this would be a valuable thing to do or not, to talk about research design. How do we decide what's evidence-based and what's real? What's our yardstick for determining value? I mean, determining reality. This is not even value. This is not even what this is even prior to value, right? This is about what's real. And
Interesting that Academy Health is interested. They really exist in the health policy space, not in the hard science space.
Well, the director, the CEO, and maybe she was just interested in getting some funding for us, but she said, we're very interested in the methodological question, okay? So I wasn't sure if they were the right group to work with or not. I don't know who to work with actually in this area. The FDA is not going to deal with it. The NIH is not going to deal with it, believe me. And so ARC might, Agency for Healthcare Research and Policy might. I could maybe approach them. I just didn't know if there was an organization that really wanted to spend time and effort looking at, what is reality? I mean, God, what's going on in our culture, right? What's real, what's not real? Jeez.
The Velveteen Rabbit problem.
A Velveteen Rabbit, that's right, exactly.
Wayne, I'd love to turn this around to something a little more positive. Larry cited your
article, the one most recently in, I guess, Kevin MD in September. But once again, it just summarized your very exciting reports from the VA's efforts in whole person care, and zero in on your sentence where you say, we got better outcomes at lower cost and everybody was happier. So what was used to measure those outcomes? Was it the traditional outcomes?
Yeah, it was actually. I sat on the cover commission and I tried to push them to do a different type of analysis. And, you know, they'd already contracted with a group that was going to look at evidence approaches using the standard approaches, and there was just no flexibility about it. But the director, at least of the Office of, Cultural Transformation, Ben Kligler, really understands this issue about methods and real and how we judge what's real and what's evidence-based and that kind of thing. So he is interested in that. So the VA has not moved into this area yet. Yeah, to answer your question, Pat, I think it's an excellent question. I think the head of that particular office is interested. I think there's some superiors above him that might support it. They're going to come out with a report, and it's that they funded with the National Academy of Medicine. We were co-funders of it. They're the major funders. We're minority funders. I put in what I wanted them to do. They ignored it. And so they're going to come out with a report on whole health, how to implement and expand whole health within the VA, which is all great. It's important. Whole health is an important paradigm and framework for doing what we're talking about here in a major healthcare system, probably the biggest opportunity for communication to the country that we've got. And, but they weren't, I doubt, we'll see if they talk about methodology. I doubt very much they'll talk about methodology. I propose that. They sort of, hem and hawed about it, which to me means they're not going to pay attention to it. However, it is possible after that report comes out that we might be able to build on it and try to get them to then say, okay, well, how do we incorporate veterans' perspectives into this, which would be the way that would be the wedge to get it in there. What do veterans want, and what do their providers want in terms of information and good evidence in order to make clinical decisions? And if they're willing to go that next steps, then we might be able to address the topic you're just talking about right now.
Oh, I'm going to share my screen here. I've got the document that you sent, Wayne, and nope, that's not it. Definitions, there we go. So I thought it would be helpful for us, because one of the things that struck me, and the reason I thought this was an important topic, is people pick up these phrases and they start running with them, and they all start writing about them, whole person care, and they start incorporating it in their teaching, and there really isn't, at least to my knowledge, until I saw what Wayne's got here, there aren't really good definitions. And just as a comment, Steve, a point that you make in your book, and you've made numerous times when I've heard you talk, is you say compassion is not enough. And I think for a lot of people in healthcare in general and in family medicine in particular, they think if you're compassionate, that's whole person care, without really, thinking about the particulars behind that. So I think having definitions and beginning to help people to understand what's involved in whole person care is, I think, pretty important. So Wayne, why don't you, this is your material, why don't you walk us into this?
Let me get on the right. Okay, let me look at it here. Yeah. Fundamentally, Larry, this is because you asked me a question, or I don't know if you asked me a question. You made a statement at FMEC. I don't know. You made some statement saying, "Gee, we need a definition of whole person care."
I did that.
I think you said that.
Yeah.
So that got me thinking, yeah, that's right. That's right. We do need a definition of that, because it is being utilized as marketing tool, and, as it becomes popular and a fad. So I said, well, let me think about how we use it in our organization, and maybe that would be helpful. And then when I was up at Duquesne University, and they're starting a whole new medical school next
Yes.
year, in 2 years, 2024. They're starting an entirely new medical school, a DO school, actually, that is focused on community-based whole person care. That's their terms, okay? So I went up there and they had a conference to announce it, talk about it, and I gave a keynote up there. And so it got me thinking, they need a real definition. They didn't have it of what are they actually doing? And at least an operational definition of it, okay? I mean, let's not get too much into the technical academic components of it, but at least an operational definition. So I put this document together to try, and well, one of the things they asked me is they went, well, what is integrative health and what is functional medicine and what is complementary medicine? I mean, it's a lot of confusion in these areas about the overlapping meanings of many of these things. So I put this together to try to begin the process of defining what we mean by whole person care and some of these other terms, including integrative health, lifestyle medicine, functional medicine. I think Joe is on the call here, who has talked a lot about that. Where does this fit in the framework of this? So I put this together to try to do that. And the fundamental thing I'll just say before I shut up is that I actually think the model we developed around the Hope Node, and we've just done with 16 clinics all over the country, with you all at FMEC, to try to look at implementing whole person care using the HOPE tools, which is a framework for saying what it is. What happens with people is when they hear the term whole person, if they really want to know what that means, they're like, oh, how can I take care of the whole person? That's like way too much. It's like, oh, the whole person, that's a lot. I mean, it's everything. It's the, and they immediately get frozen because they don't actually know what that means. So what we've tried to do in these definitions is define whole person care. And what I've done with these definitions is I've taken Maslow's hierarchy and I've reorganized them into not a hierarchy, but a sort of a network-based system in which the physical body is in the outside, which is how we all see it. The behavioral component is a little more hidden, the social and emotional a little more hidden, spiritual and the mental a little more hidden, but they're the core component of what a person is. And defining a person that way. So it's like a redesign, if you will, of Maslow's hierarchy of what it means to be a fully functioning, flourishing human being. And that then is how we've built our operational tool. So it's an operational definition to say, if you want to do whole person care, all you got to do is pay attention to these 4 areas. That's all, okay? Ask people and address and talk to them about these 4 areas, and you will be doing whole person care. Okay. And so that's the approach, because our goal here is to try to make this, as operational and routine as possible. So it's an attempt to take the smorgasbord of the confusion over whole person care, use Maslow's hierarchy, reconfigure it, and then put an operational set of tool set that say, all you got to do is ask about these 4 areas. And you will have covered, what it means to be a whole person. And if you can see this in a person that's sitting in front of you, you can see that they have a spiritual and mental person. They're sacred in some way, that they have a social and emotional body. They have behavioral issues that they need to have addressed, and they have physical and economic needs, okay, in those areas. You are doing whole person care. That is the definition of it. And then that's what we need to do. And you do it by having a relationship with them, okay? And figuring it out and doing their personal determinants of care. So that's what these definitions are an attempt to go after. And it is really is helped. We tested this out in these 16 groups. And it's interesting, they readily adopted it. They were great. They never really they didn't really, they thought that the framework provided with what they needed, the challenges that they had were much other issues. They were time, they were payment models, they were, research, they were practice design issues, can I actually do this where I am? And that kind of stuff. There weren't questions about, is the definition and is the framework a problem? Is the term a problem? And were the operational tools a problem? None of that was a question that came up. They were mostly about how do we actually do this? And so I think to me, that's why that to me reinforced the fact that we at least had our definitions and our frameworks adequate. I won't say they're right. Truth never, it doesn't exist. It's an illusion. But, for right now, is this a useful concept? And I think we got confirmation, and we're going to publish an article about this in a major journal pretty soon. On the fact that they said, yeah, this is what we need to do in family medicine. Most of them were family medicine primary care groups.
Yeah,
I want to welcome Joe and Scott, who just joined. And what we're doing is we're right now responding to Wayne's definitions that he shared with us. And we're talking about what is whole person care. Steve, I'm going to ask you first to react to what you're hearing from Wayne.
Okay, yeah, thanks. Well, I think Wayne's just a swell guy.
I'm sorry you said that, because now I don't trust you a bit.
No, I think you know what I'm going to say. Of course, yes, this is a good framework and a good starting point. What I think is the missing piece, to go back to our earlier discussion, is once you have this information, you have to know what to do with it. Let me give you an example, okay? Let's say you find out this person is following her parental model for whatever reason. Her mother was a hypochondriac, and she is too. She got sick every time she was burdened with parental responsibilities, and that happens with your patient too. Okay, so you've learned that. Let's also say she's brought up Catholic and she feels guilt-ridden because she may not know this, but she had an abortion when she's 16, and you suspect that guilt is underwriting. And further, to make matters worse, you learn, and I'm taking these from actual cases, you learn that when she was sick, not really, when she wanted to stay home from school as a little girl, she got a sore throat. Her mother would make an assessment. If she wasn't too sick, they'd go have a spa day and ice cream. So she has a heavily and multiple times reinforced retreat into illness pattern as a part of her underlying whole person. So what do you do with that? I would argue, if you don't understand the nature of the causality that underlies symptomatology, you're dead before you start. And then if you do, so that you can see what the multiple causes, because I think the only thing, this is just me, the only thing axiomatic in medicine to me is that nothing ever happens from a single cause. No symptom ever arises from a single cause. But let's say you have that, then you still need the knowledge of how to treat these contributory causes. And again, as Larry said, compassion's not enough. It won't get you there. So I think it's a perfect starting point. But to me, a history is really about a keen hunt for causes. That's what you're doing when you're taking a history. Yeah, you want to know the person. Yeah, you want to establish a relationship, and those are part of the skills of, I think, being a effective primary care doctor. But you're hunting keenly for causes, hopefully with a knock them down one after the next until you can return the person to health, or give them tools to maintain and assure their health. So that's how I look at it. I think, Wayne's a practical guy, and he understands that we need to keep things simple and teachable and ground them in acceptable terminologies, which I think all of this does that. I'm just advocating for next steps.
Can I ask a question to Steve here,
Yeah.
Larry? So Steve, the question I have for you in terms of the causes is that more important than helping the patient find solutions, which are not always the same? If they have a pathway into healing that may not get at sort of the fundamental causes, but it gets them along the journey towards doing that, then isn't that a sort of a more generalizable framework or an approach that we might take? And I know that you're focused a lot on the noetic components, which I think overlap considerably with what I call in my approach, my framework, the mental and spiritual components of it. And I've debated here a while. I'd love to get your thoughts and other people's thoughts about, should we use the term noetic instead of mental and spiritual, or spiritual maybe, which has all kinds of other baggage on it. And I just wonder, I don't know this, is the fundamental approach we're trying to get. And I say this because I just reread Gail Stevens's description of healing and definition of healing, in which the guy went mystical on us. I mean, he talked about transformation of, I forget the exact terminology, but it was basically a spiritual transformation. It's finding that link to the, what I would call in your terms, Steve, noetic, and I'd call in mine sort of spiritual component aspect of it. But isn't it true that people can get there through a lot of different pathways as long as they start on the journey? And they may start by addressing sort of their emotional needs. They may start by addressing their social needs and economic needs. But as long as they're engaged and active in trying to seek out their own inherent healing processes, will they get there? And isn't that what we should be doing? Or should we be trying to move them towards, this underlying fundamental causes on a noetic level?
Well, yeah, let me answer that in two pathways. But begin by saying I don't think I have a full answer for that at this point in time. I would say first, one thing that's important is, at least for understanding, is that when these causes are recognized by a doctor, it doesn't mean, and it often doesn't entail, describing these back to the patient. There are better ways to deal with them than what I call the blurt, where you just say, "Oh, you're being your mother." That's not going to be effective. But I think they're very important to know as part of, at least for me anyway, the first interview. So I know what the prime motives are within the personality. But that said, if let's say, for example, the road to health for a person is lifestyle changes, and getting them on that road, and all of that can be done in the absence of addressing these causes. Let's say they're healthy and mature, they've properly disidentified with their early childhood authority, and they can get there. That's primary. You're right. But I think, how many times have we all, as primary care docs, just given information and advice and really done the best job we can at that, only to discover that there's something holding that person back. There's some reason they can't get at it. They're not doing it. And those impediments, in my experience, almost inevitably trace back to these kinds of causes I'm talking about. Not always, but almost inevitably. I don't know, Wayne, where the balance is in there in terms of what's prior and what's not. I do know, and there are a lot of confounding factors here, like time. I do know that, the greatest failing of primary care doctors is this sort of informational blurt with no outcome. It happens with almost every patient one way or another, compliance issues and so forth.
Yeah.
It's kind of a fuzzy answer, but what it drives us to, I think, when is, and we should be able to answer this, is what's a normal healthy person? And I often say to my patients, I just did this. I often say to my patients, what would a normal healthy person do in this situation? And which begs the question, well, yeah, what is a normal healthy person? And I can give you the simplest definition of that. And I think it's actually operationally effective. But then it begs the question, how do you become that? And how do you nurture your patients to that point? Seems to me a normal healthy person is someone who at each choice point makes a healthy choice. And by choice, I mean not something driven programmatically by either a conditioned response or a imitative imperative, but rather a choice, an independent adult choice. And what I find is, regardless of age, that's a rare beast. And so if you're talking to a normal healthy person saying, here's the deal, you've got, I don't like this calcium T-score. Here's what you've got to do in terms of change. I know you want to enjoy your 70s with your grandkids, etc. We won't make that healthy choice based on information. That I think is what I'm driving at with these contributory noetic causes. I don't know.
Larry, I'd like to offer a comment. And what I'm about to say, I don't want it to come across as flattery. I want it to come across as an observation leading to a point I want to make. But I feel privileged just listening to Steve and Wayne discuss this, because I feel like I'm in a salon with two of the most deepest thinkers about healing in our specialty and really in our profession of primary care medicine. And it's a privilege to listen to it. And you both have written fabulous books. Wayne's book is loaded with examples of healing that exactly is like healing in Steve's book. And it requires, different elements of, it requires time, it requires insight, it requires a deep sense of patient-centeredness. And, I think, what Wayne, you're going after is exactly terrific. However, we're living in a healthcare system that really doesn't care that much about healing. There's not like there's a call for healing. And, the guy who wrote A Time to Heal and the follow-up books, I mean, it was a great book and it was talked about a lot, but it didn't revolutionize our work because we live in a wealth care industry, and this industry that cares more about productivity and we train residents to be expedient. And when you're being expedient with patients, you get this treat them and street them mentality. And I'm constantly, this morning as I was a preceptor, I keep challenging the residents. Is your interest in making this patient helping this patient become healthier? Are you a healer? And it's kind of like I'm talking a different language to them. And they say, well, yeah, but, and it's just fascinating. So anyway, in coming into the call, Larry wants to use our group as a way of changing the world and creating a revolution. And, he'll never give up on that quest. And it would be wonderful if it happened. Dale Stevens sparked revolution because of the timing of being there at the birth of a new specialty. And the real question in my mind is, I think, Wayne, every time you apply whole person care, whether it be in a VA model or somewhere else, the outcomes are going to look terrific. And but then the question is, where's the spread? Now, I know you've accomplished spread within systems like the VA and others, but to get the spread to really get out there, and Steve, you are a iconic figure that is, I feel like your spread hasn't even happened to one of your buddies like Mark Kalina or somebody. Now I'm being presumptive there, but how do we turn this into a revolution?
Joe, that's an incredible and important point. And we've got on this call Scott, Michael, and Len, who are all and Pat, but all that are involved in different approaches to spread that have been trying to spread this. I love to hear what their thoughts are about, at this time, what is needed, or should we just all give up and that would lead to spread? I'm sorry, I didn't mean to be that pessimistic, but I've been studying Buddhism recently and they said give up on all of it. So that's a way to make it happen.
I'm really curious to hear from Scott, because that's where the rubber really meets the road. Scott's been trying to train doctors and set them up in networks to really change the way primary care is practiced very successfully, and
get payers involved,
affect large systems and do it within a changed financial structure. So give us some hope, Scott, that these concepts we're thinking about can be brought into a new version of primary care within the current economic system.
All right, can you hear me okay?
Yes.
Yeah.
Okay, hey, can we ask you to take the slides down so we can see each other?
Sure.
Yeah, it'd be great. Yeah, so Larry and I and Mike Tuggy, I don't know if you guys know Mike Tuggy, but we're in Queens right now, and we're up for our end of the year meeting. And so, your point's well taken, Wayne. We just have moved over to the full risk group. So, 174,000 full risk Medicaid and Medicare patients, and we're reinventing their entire primary care system. I mean, it is on the ground. It is going hard. It is, it's very interesting because we literally have gotten to the point where we're saying, guys, you got it backwards. In fee for service, you have to do things to get your money. With capitation, you get your money and then you do things.
yeah.
So quit thinking backwards. You've already got your money. Now you've got to figure out how to care for people so it's not wasted and you control it. So it sounds stupid, but I swear 60% of what we had to do this year is to get them to flip the way they're thinking. Now, once they've flipped that, now they can ask the intelligent question. And that is, well, what do we do? So we have a schism. I mean, I'm maybe going into more detail than you want, Pat. But just, this year, if I were to give you a high level, we had a schism between the business side of the big system and the clinical side. So the clinicians got it. They're like, oh, okay, we understand this. And Larry, by the way, is here. He's our historian. He's watching it all. He's seeing it all. He's keeping track of it all. So Larry, jump in here when I stop here in just a minute. But the clinicians got it. The bean counters didn't. So we had to declare war against the bean counters and go at them really, really hard. That's going to finish tomorrow. We have moved the pilot we did from 1 clinic to 3 clinics. We go to 8 clinics starting at the beginning of the year. And we have redefined. So the other thing that's just like, oh my God, you've got to freaking be kidding me, is KPMG is here. And KPMG is trying to get them to set up their bonus program based on RVUs billing and collection. And we're like, what are you doing? That is so stupid. It doesn't matter. And they're like, oh, it does matter. We're like, no, it doesn't matter at all. It doesn't matter at all because an RVU is useless. You know,
Yeah,
now
exactly.
getting
It's actually
preventive service is good.
counterproductive.
It is. So
Yeah.
we had to go to war with KPMG, which by the way, the state put here. And so,
Exactly.
so here's the end of the day. So here's what's happening at the end of the day. So we've got the whole person risk score. And by the way, Wayne named that. It was the clinical risk score that I developed. I was calling it Marcus Welby, or the Fromer risk score. But Wayne said, you got to call it whole person. So now it's the whole person risk score. And for those of you who don't know, Steve, I don't know if you ever heard this before. It's got I'll be quick, three components: the absolute risk of the individual, the clinical care that they're receiving, and how they're using the system, how they're accessing the system. And it's an integrated 360 that includes social determinants and behavioral things and so forth, that looks at that person in the big context. So that is being put into their Epic system, Wayne. I don't know if you know this. So the receptionist and the telephone operators now, when they pull up a patient, it will have that person's risk. And what's happening is if they're a low risk person, so then the first question they ask is this a routine visit or has something changed? If it's a routine visit, they just do next available, they schedule that. If it's something's changed, they look at the risk score. If it's a low risk person, they get the RN nurse at the clinic on the phone to triage. If it's a high risk person, then they walk them in that day. Like they get them in to get them taken care of, because we can't have them going to emergency rooms or other specialists
that's
or
right.
landing in other doctors' offices. So we've got the whole person risk score that's now done. We reinvented the what we call the high value visit, which is the 45 minutes sit down and get to know your person and really make a plan. And what happens now is that there are 2 in the morning and 2 every afternoon, and they're doing proactive outreach to the high risk people and filling those spots with high risk people. And then they'll spend 45 minutes. Now, at the end of the 45 minutes, the job of the practitioner, clinician, we're calling him because Larry told us that's what we should call them. Clinicians will have a care plan. They hand it off to they leave actually the navigator comes in and they say to the navigator, what does this person need? Here's what the person needs, and they leave, and the navigator gets everything arranged, including the next follow-up appointment. And then, so the person now is moving through their care pathway, and they give the person the navigator's cell phone number, so that if they have any questions, they can get a hold of them. So to make a long story short, we have completely reinvented that entire process flow. We've gotten it in place. We've gotten it in Epic. We've gotten the buy-off of the leaders and the managers. And next year, so the final thing is that we have a report. So this is the bonus structure for the primary care doctors. And what it says is what percentage of your panel have you seen and done a care plan on? What percentage of your high-risk people have had a high-value visit? In terms of the gaps in care or the clinical quality, is how well have you done? In terms of identifying risk in people, how well have you done? And those metrics. And so we have, you'll get a kick out of this. We call them PCP homeless.
Great.
And so we have what percentage of their people are PCP homeless, what percentage of their people are medically homeless because they don't have any doctor, then how many of them are lost? A lost person, somebody who's gone to a specialist, ER, inpatient, gotten imaging, and they haven't seen their PCP doctor. So we report back to the doctor how many of their people are lost and homeless, and then how many people are getting appropriate care, which we define as they're seeing their primary care doctor actively and all of their cancer screenings done. How many people are healthy? Healthy is they're seeing primary care, cancer screening is done, and their numbers are to goal. And so we report to them what percentage of their practice is healthy. So now they've got, and their bonus structure is being set up based upon these 5 metrics. The other 2 metrics, by the way, are patient satisfaction and and care team satisfaction. We do quarterly surveys. So we've got this dynamic model where we're flipping the whole mentality. We're teaching them the art of medical leadership. So we have a whole leadership development aspect of it too. And we're redefining the incentives, and we have taken on the whole world to do it. I mean, it has been like, holy cow. If you guys see Alan Roth or Gino Tulo, you got to go give them a hug, because they are in hand-to-hand combat here every freaking day.
Yeah. So Scott, I hope they're paying you for this, because we gave them some money to do it. And when we stepped out of it, you've done a great job once we got out of the way.
No, Mike Tuggy and Susan Lindstrom, who's my partner, and Larry and I, we probably are charging about 20% of what we're actually doing. But what our thought is, if we get this, or when, I'll say when, right, Larry, when we get this going, and we can show in the most ethnically diverse suburb in the United States with Medicaid patients, 174,000 Medicaid patients, that we were able to transform care, that we'll be able to scale this across the country to other full risk groups. And that's what we're banking on.
Yeah. And CMS has eyes on this. And as you move along, Scott, let me know how you're going. And we'll get it up to a little higher than CMS, okay? If you want.
Yeah, and Larry, I'm going to ask for your help on that. We do these reports. We quarterly compute all the results. Maybe on one of these meetings, we could show you all the metrics that we have and how we're tracking, monitoring, and managing them. By the way, one additional thing, we discovered $63 million that they are paying out to specialists and emergency rooms and urgent care centers, because there's a group of people we identified. Out of the 34,000 people they take care of, 1,500 of them are quote unquote wasting 63 million, because what they do is they go to the specialists, and then if they need a primary care doctor, they go to an urgent care or emergency room. So the primary care doctors who have been assigned those patients never have seen the majority of them. So we've found them. We're going out. We're literally they're going to hire 5 basically kind of barefoot doctor social workers to go into the community to find these people and give them a choice. You either get on board and get in our primary care clinics, or you find a primary care doctor close to home we can reassign you to, but you can't continue to behave this way. Yeah,
that's great. Call them on it. So there, Larry, there's your definition of whole person care in action. Yes. But what Scott's done is he's added a very, very important term, which is whole person risk. And that's made it operate much more operational than what I've done.
Well, I have to tell you, just to follow up on that, what's really impressed me is the data analytics behind this are really pretty phenomenal. There's no one else in the country that I know of where the docs are getting, the teams are getting these kind of dashboards where they're able to identify proactively these different cohorts of patients, and there are different strategies for responding. That's the data analytics is really impressive. The second issue is the practice transformation. This is a safety net hospital, as you know, Wayne, and safety net hospitals probably are the most entrenched in terms of how they think, what their culture is, and how they behave at the practice level. And the transformation that Converging Health is stimulating at the team level is really impressive. And it's the harder work, quite honestly, from my point of view. Just people thinking differently, behaving differently, reconceptualizing what their responsibilities are. I mean, it's pretty profound. So it's very cool.
I agree. It's much harder, and it is even more essential than many of the other aspects. It's absolutely essential to the change. Yeah, and it is hard. Great.
Scott, when you were talking about, your measurements and your feedback and how satisfied the patients are, which is a critical
metric. Do you incorporate how satisfied or how happy the clinicians are?
Yeah, we do the entire team. So
That's
every
team.
3
That's
months,
the team.
yeah, every 3 months we send, and it's pretty straightforward. It's got like 5 questions, and it's really oriented toward how well you feel you can live out your mission as a healer. So do you feel like you're able to realize your purpose at work as a healer? I mean, it's like literally one of the questions. And then do you feel supported by the other people in your environment? Do you feel, and I could get you the questions, but anyway, we did it based not on, how happy are you or how good do you feel, but how much can you live out your mission? And that's the transformation that Larry's talking about. We tomorrow, Friday, we actually are doing a full day workshop with all of the employees. They're closing down 8 clinics and bringing all of the staff in for us to do this workshop with them. And I'm strongly considering, I got to get Mike and Susan and Larry's permission, but starting off with a scenario where a nurse has a car accident on the way to work. She's going to be an hour late. 2 patients are sitting in the waiting room. There are other nurses, and the doctor walks in and sees them, and they all go to their office and fume that this nurse isn't there to bring the patients back. Right? And my point is, have you guys ever seen the video on the people that are on the escalator and the escalator stops?
Yes.
And they're yelling, help, help, somebody come rescue us. We're stuck, right? All they have to do is walk. and that's literally the kind of stupidity that we see here, where the doctor, instead of walking out and rooming the patient, that's not their job. The other 2 nurses that work for a different doctor, well, that's not their doctor. So we have 5 themes. One of them is we transform communities, and all for one for all. Shift happens, which is shifting from that mentality of it's not my job and complaining about other people to I'm living my mission. Disease is the enemy, not each other. And then we have one that says believe. What's the soccer coach that used to be a football coach in England? What's that show?
Ted Lasso.
Yeah.
Yeah. And how he has
Ted
a sign
Lasso.
believe, believe above his
Believe,
yeah.
Yeah.
We're gonna put that above the door and have everybody tap that as they come in and out of the room. Right.
Right.
So it starts with the change in, and they eat each other for breakfast here. These are New Yorkers. Like when that nurse came in that day, when that nurse came in, they were like, what the hell? What's your problem? Why weren't you here? And she's like, someone ran a stop sign, T-boned me. And they're like, that's a stupid excuse. And they just attacked her instead of, helping each other out and taking care of people. So we've got, it is a huge, almost overwhelming at times job. But you know what? Because of Alan and because of Gino, we're going to make it work.
Great.
Yeah,
So
I was
am I
smiling
good?
the whole time through your entire story. You just described what fills my days, but from a different perspective. So yesterday and today, we had our kind of early in the week healthcare 101 sessions for all the financial people I have to work with who don't know anything about healthcare. And we're talking about everything you just said. The core of how do you shift to a patient-centered, team-based, whole person care mentality? How do you try to align with the payment model in the system and build the facilities that form follows function and supports and empowers the teams to do what they do best? It's just wonderful to hear what you're doing. Everybody, I think, on the call knows that Alan Roth has been trying for years to make a dream come true of having an integrative care center in that county. And that same state that's sending KPMG in with the incredibly stupid thing they want to do is doing it because they write a check every month to make up for the deficit that system runs because the state doesn't pay enough for the primary care services that are going to keep people out of the high-cost hospital and ER and urgent care centers. And if the state simply signed a guarantee to pay the rent, that integrated care center would have been built and open by now. I mean, it's just unbelievable how bass-ackwards the system is. And Scott, I love your passion about trying to fix it.
Well, I appreciate
And
that.
spread.
And
And spread the ideas we're talking about here. It's wonderful.
well, thank you. And Len, you and I have been doing this for a long time. I remember you showed up in my office one day, way back in like 1996, asking me what the hell was going on. So it's been a long time.
And you had written on the four walls of, I remember the four walls of your office, you had all of the care patterns and pathways and evidence-based stuff and how we're going to change. I mean, I can't believe it was that long ago. It's amazing. Yeah. And it's reality now and you're doing it.
Yeah,
Awesome.
but it sure did take a long time. Holy cow. I thought we'd be where we are now in like 2005. And here we are, 2022. I'm going to die before we get too many of these.
No,
just-
you're not going to
You're
die.
not. Just take a deep breath and think of Neil deGrasse Tyson timeframe, cosmic timeframe. It's a drop
Yes.
in, in the
That's
cosmic timeframe.
You're only going to die when you give up, Scott. So
Yeah.
just,
Well, so the one thing I would tell you, I've really was a revelation to me this year because I'd really forgotten about it, is the Art of Medical Leadership, the program that Susan Oran and I did when I was managing 510 docs. I got to tell you, we were getting stuck in the mud until we took that out and started teaching it. I mean, it's crazy how you've got to shift mindset first, and then you can get operational change. When you try to get operational change without shifting mindset, you're going to fail. And I think that that's like a huge concept that people are missing in transformation. And I think we
Yep.
need to come back and remind people of that all the time.
Scott, I'm particularly impressed comparing what chin medicine is doing. They take doctors out of training and they don't let them see a patient for a month. They give them special training in the chin approach towards exactly what you're talking about. How do you analyze, and they only give 400 patients per doctor team, and every visit is 30 minutes. I mean, that's
Sure. Yeah. My daughter is a family doc. I had her interview with them this last month and learn about their model, because I think that is the future. I wish they would buy my damn whole person risk score. That would just change my freaking life. If anybody knows an integrated delivery network that needs a really functional, proven tool to risk stratify quickly so that somebody who's got a GED degree all the way up to the head doctor can know where to focus their resources. Man, if I could sell that about 5 times right now, I would change my life, because it's expensive to develop an IT program. I got to tell you.
what about Walmart?
I've tried to
Walmart
reach out.
Health, Wayne, great example. Walmart
Yeah.
Health, David Carmouche,
I reached out
Omnichannel
to
Care.
Yeah, I tried
Talk
to get
to
a
him.
hold. I tried. I called him. And I've left like 6 messages.
Well, the
but it sounds like-
woman, no, you got to get the right person. It's the woman who's their chief medical officer. I forget her name right now. I've only met her once. Actually, I've not met her. I've only met her virtually. Is that real meeting? Anyway, the woman, she's African American woman who's. Have you talked with her?
No, I didn't even know she existed in the world. I thought David Carmouche.
Let me ask her. She gets this. She knows it. She wants to do it. She's the chief. I'm probably very frustrated. Let me explore that.
Thank you.
I'm not sure if they can do it because CVS, Aetna, Amazon is now involved in it. Larry, we need Rashika on here to tell us what's going on with Amazon's purchase of One Health, which purchased Inora. It's
Inora
the
Health.
clash is about relationship-based versus service-based care, right?
I did, Wayne, talk to, I communicated via email, and he said yes to the meeting in December. So this meeting next month, hopefully
All
he'll
right.
be here.
Well, gear up your hard questions for him because Amazon now owns them. And you see what they do.
Yeah.
Wayne, are you talking about Cheryl Pegas at Walmart
Yeah,
Health?
Cheryl Pegas, that's correct. Cheryl Pegas, yeah.
Oh, Vegas.
Shouldn't we have a discussion with her?
Would love it.
Cheryl Pegas. All right, let me see if I can find her.
Pegus.
That's correct. That's correct.
Wayne or Len, can you introduce Scott to her?
I think I can.
I don't
Yeah,
know
I've
her.
got,
Yeah,
I don't know her directly, but I've got a pretty close connection with that, and I think so.
I know David and talk to him regularly, but I don't know Cheryl yet.
Yeah, there was an opportunity a year ago with the Whole Health Institute to really get engaged with them.
Mhm.
But now that's starting to fall apart a little bit because of the Alice Walton Foundation, which sponsored the Whole Health Institute, is I think in chaos right now. So, but there's still some connections there within the Whole Health Institute that I think could do that.
Yeah, you had me meet
Wayne?
with them and talk
Yeah,
with them.
me too. Me too. Same thing. I was just going to say that,
No,
Wayne.
well, let me
So
explore that. The Whole Health Institute, which was Alice Walton and very connected to Walmart, as you can imagine, the Whole Health Institute is really in chaos right now. Tracy Gaudet, who led it, left. Her replacement that they brought in, they left. I mean, they're in real chaos, but there's a person there right now who's very connected to Cheryl. And so let me explore that and see if through that avenue we can at least get a conversation with Walmart, which is different than the Whole Health Institute. Okay. Because the nice thing is that they need a competitive advantage. Okay. I mean, Amazon is the elephant in the room here. Okay. And they need to figure out how they're going to compete with that. And I think they need this kind of thing, as at least we should offer it to them as an option. We'll see what happens. I think Cheryl would probably get it. From what I've heard from her talk she's given and others, is that she understands the need. But whether they would pick it up as a competitive advantage, CVS just declined. I had just had a conversation with the top CMO at CVS, and they declined to go this direction. And because they've got their own market issues. Confidentially, I'm sorry, this is recorded, maybe, and I shouldn't say it. I think.
Let me turn the recording off at this point. I think